Welcome to only the second in our series of talks entitled Terrible. Thanks for asking. So these are all about understanding the issue of lightening the load, really, coping, as that's been brought so much more to the focus in the context of the pandemic that we have and continue to live through, but more generally the way that that's drawn our attention to the importance and the complexity of these issues. So we're very delighted to welcome you to the second of the series. We across it, we'll be hearing from a wide range of professionals who've generally been in the front line in health or education, social care and welfare, by and large. We're delighted to have the opportunity to hear a bit about their careers, their lives, and the learning that they made along the way about coping, supporting others, looking after themselves, and the challenges to their well-being. And of course, as I say, the salience of this seems so much greater as we come towards just over a year now, really, since the really tough part of the experience of the pandemic has been affecting us in the UK. And I just want to say right now, before we start, a thanks to our senior common room, college senior common room, for their support of this series, and now to Steph, who is kind of co-chairing with us, whose conception, beautiful conception, this series has been, and has done such a lot of work to organise it. So thank you, Steph. Our special guest, and let me introduce her to you. So Dr Kasia Maksym, who's a specialty doctor and senior registrar in high-risk pregnancies at University College Hospital in London. So I suspect one of the UK's largest hospitals, and a lot of the specialist centres there. And of course, somewhere, if we think, when we do talk a bit about how things have been this year, that's been right in the eye of the storm, really, in terms of the impact of pressures on health service and the staff. And Kasia works there in the Maternal and Foetal Assessment unit. So it's a warm welcome to you, Kasia. Thanks for joining us this evening, giving you time.
Thank you very much for having me.
It's a pleasure to have you here.
Yes, this is a big hospital, maternal fetal, and also fetal medicine and everyday work on labor ward. So quite a mixture.
Quite a mixture. So I was gonna just say, that would be my opening question to you, really. I mean, for people here who come from a wide range of backgrounds and expertise themselves, but could you just give us a kind of sketch? So what's that job mean? What is that speciality, and what's the kind of context for the work that you're doing then?
So basically, the 50% clinical which I'm having is senior obstetrician and gynecologist, senior registrar in obstetrics and gynecologist. So that is pretty much everything around pregnancy, doing some clinics. I'm a little bit special because I'm doing scans as well. I can scan and having on calls on labor wards and operating in theaters and everything, a little bit of everything. But because of my other 50%, which is studying for PhD in high-risk obstetrics, and partially clinical, partially in a lab, that brings me more towards maternal fetal conditions, so and fetal medicine as a whole, and I'm working with very high-risk patients, basically.
Okay, thank you. So thanks for that sketch, and I think we definitely want to hear a bit about some of the research that you're doing as part of the job. So how did you get there? How did you get to be in this role? What's the story of getting into medicine, and in particular specialty?
So getting into medicine, it was probably it was a little bit of accident, actually. I wouldn't change it forever for anything. But it was a little bit of accident. My both parents are engineers, and my mother's sister is an architect. So my dream was to be an architect or do some mathematical physics stuff. But then we went for a birthday. We went hiking for a weekend, and that was birthday of my best friend. And we had these conversations, around midnight. And my best friend said, listen, well, you will be good with mathematics and physics and chemistry and everything, but you are so good with people. Don't waste it. Be a doctor. So I changed my mind, and within half a year, I prepped myself, passed an exam, and here I am. And then I finished university, and I was doing my internship, and I was all about becoming a surgeon, and especially in transplantology. That was my big dream.
Okay.
And then I couldn't get a place for training. So my next placement on the internship was obs and gynae. So that was again a little bit of the accident. And I got hooked up and I never left. So I guess you have to take what the life deals you, but listen what has been dealt.
Okay.
That's it.
And what was it about, landing in obs and gynae that really made you think this is where I want to be?
I had some surgical skill to start with, so it was a little bit easier than my colleagues who hasn't been involved in surgery before making this decision or before coming to the specialty. But also, gynecology is very surgical, but obstetrics is a very special, different thing. You have 2 patients in one or 3 patients in one sometimes. This is not a just surgery. You're saving 2 lives sometimes or 3. So that was a little bit of this magic, which get me.
Okay, and then thank you. So tell me about the clinical part of the current role. What's the context of it? You talked about working with very high risk women and babies at very high risk. Is that right? So what's that work look like?
So because I can scan, this is not. I'm obviously not. I'm not obviously not British. I came to this country 15 years ago, and I started my training back in Poland. And part of the training in Poland is ultrasound skill, which is not a part of training for trainees here. We have special people doing ultrasound, sonographers.
Okay.
But the people like me who are coming with this skill to the profession in UK, we sort of cling to it as an extra value. And because of that, very often we are put in the positions where we work with the patients who need extra scans, extra expertise. And this is what has happened to me. So I got involved in high-risk pregnancy cohort with the patients whose babies are not growing, are very small, struggle inside, and they need a scan sometimes twice a week. And this is why this high risk and pregnancy and this is why my PhD started.
Okay.
Very special cohort, not everyday small babies. My cohort, the very small babies, weighing sometimes less than half a kilo, and very early in pregnancy, and after delivery they struggle, and we have a lot of connections to my patients.
Okay. Do you tend to see the patient journey right through them from kind of when somebody's booked in, when a mother's booked in?
Usually the story about the condition, which is called growth restriction, early onset growth restriction in my case, usually it starts around mid-pregnancy. So the first initial bit is all normal, usually low risk or some risks involved. That the patient is seeing midwife, and then she's coming for a scan at 12 weeks, and then the pregnancy is going okay. And then she's coming for 20-week scan, so the second scan in a pregnancy. And then sonographer measures the baby and is saying, "Ooh, this baby is too small." And then patient is referred to us. And then we take over, and usually the rest of the pregnancy is with us.
Okay, so still fairly early in the patient journey. What are the? I mean, are there characteristically the kind of concerns that those patients might be sharing with you at that point when they make that encounter?
So this cohort of the patient is very special in fetal medicine setting. With majority of the patients who are coming to fetal medicine unit, there is a problem with the baby. There is a hole in the heart, or there is a problem with the kidneys, or there is a problem with the brain, or there is some kind of condition visible, well defined, and we can scan the baby, and we can speak with our pediatrician colleagues or neonatologists, and we can tell the patient, listen, your baby has this and that condition. We can treat it this and that. When the baby is born, baby will born in this condition, will need a surgery or will need something, and it will be good or it will be bad. But we can give some solid information about what can happen within the pregnancy and after baby is born. With the growth restriction patients, and especially these very early, on the border of baby viability, we cannot give them any solid information, because I don't know if this baby will survive or not, because everything depends how the pregnancy will progress, and this I cannot predict. And this is very hard on my patients. They don't know if this baby survive. And because the mortality rate in this cohort is for the baby is very high, we're talking about 32%. So third of the babies will die even before they are born. So this is a huge pressure on the patient. And additionally, because these babies are so small, the mom sometimes she cannot feel baby moving. So she is living from the appointment to the appointment, not knowing if the baby is alive, sitting in my waiting room and literally being absolutely in a limbo, and coming and closing eyes on a bed saying, like, just tell me that the heart is there, that the heartbeat is there. Sometimes they cannot speak before we confirm that the baby is still alive. Because of all of this, and because of this very different psychological problem for these patients, we started testing. So we started giving some questionnaires at the time when we diagnose the condition, and at the time after she delivers the baby, and we started measuring anxiety levels and depression, and measuring the post-traumatic stress disorder, and the levels are extremely high.
Okay, but is this part of the research that you're using for your PhD? Is that right?
Yes, this is part of the research. It will be one of my chapters, I guess. But a part of that, I'm planning to use it to improve the service, to make sure that these families, because this is not only the patient, this is the partner, this is the family, friends. I just want them to have an opportunity to reach for help, to make this reaching for help easier.
Okay, thank you. So, I mean, it would be good to hear. I think we want to talk a bit more about that, if that's okay. That experience of what you're learning from it. But I'm kind of also trying to understand how this is for you as a space to work. How how you manage to function in an environment which is so, in which your patients are experiencing such a lot of stress and difficulty, profound existential stress. How does that for you? I mean, what kind of person are you that can manage that, Kasia?
I don't know how I can manage it.
Okay.
It's very hard. This is really hard on me. It's generally obstetrics. If everything is going well, it's beautiful and happy and over the moon. But if something is going wrong, usually it's going wrong very badly. So the obstetrics is enough, but high risk pregnancy and this kind of condition in pregnancy is hard on me. I'm bonding to these patients. I'm seeing them every week for 10 or 15 weeks. And I'm coming and I'm doing cesarean section and I'm seeing this tiny little chicken born. And then I see the baby struggling on neonatal unit. Is very difficult. I have to be professional, so I'm trying to be professional, but I'm bringing it home. Yeah. And I won't cry in front of the patient probably, but home, yeah.
So a lot of occupations kind of had this requirement of the emotional labour that goes in, what we're talking about. And sorry, the sun's really shining, isn't it? I'll probably turn into a shadow here. And there's something about where you find the support and the resource to manage that and continue to present that professional face, really. Where does that come from in the environment that you're in? I mean, is there a professional network? Is that part of it, Kasia?
So it's very important the team you work with.
Okay.
Because if you are a little bit senior in this team, then you have to lead the team and you have extra opportunity to show the ways of helping the other in your team to cope with this one, and especially if you have a junior midwives or students or junior doctors coming, they need this support. I'm lucky because the people who are around me, they listen. They listen, and it's easy to reach to them and say, I'm so sorry for this baby. I'm so sorry for this mom. I'm worried about this baby. And they know this is the worrying in professional way, and we talk about it. Talking is good. And the other thing is trying to put yourself in the patient's shoes, okay, to see the things from their perspective, because then I adjust my behavior and sort of talk to them slightly different way. Mm-hmm. And sometimes they helping, even not knowing, they helping by trusting me. I know it sounds weird, but no. There is something like that.
Yeah. No, I understand that. So that investment that you're making, I mean, I understand now something about the motivations for it, and kind of the costs. You've said, the empathy cuts both ways, right? That it gives you space to understand and be in a place that's more supportive for them, and also that relationship feels good. What I'm thinking about, I only want to keep you going for 5 minutes before we take a break and then come back to the PhD issues, really, if that's okay, and what you're learning from that. It's just to understand this, right? Maybe as a way of going beyond. This is clearly an incredibly stressful and difficult environment. People aren't there either working or as your patients because things are going well. But sometimes they do work well, and things come out with a good ending, don't they? Even if it's at a few occasions. What's that like? What's that experience like for you, for the team, for the mother and the family?
This is absolute magic, and this is the ultimate fantastic feeling when I have a mom coming after some time after delivery, sometimes even after a year, and look, this is your baby. This is your auntie. She delivered you.
Okay.
This is like highest possible price. I'm taking picture with them, with permission, and I hold it on my phone. And when I'm really low for some reason, I'm looking at these pictures, and sometimes I'm getting a card, and the cards are sitting on my wall, and when I need support, I'm looking at the cards.
Thank you, Kasia. We've been talking for about 20-25 minutes now, and I feel like we might have reached a little point where we suggest to people we take a couple of minutes, particularly you know, you do this for a living, and here we are on a Saturday night asking you to live it all with us again. But if we invite people to just check out for, I don't know, for 5 minutes perhaps, but when we come back, what I'd really like to do, if that's okay, is to understand a bit more about some of the issues you've been talking about, the way that mental health is configured into this environment. Maybe if you're happy to, tell us a bit about this piece of research, what you're learning from it. And then you know, we might have moved along with a little while ago. Perhaps that'll take us another 20 minutes. And then we've done this in the past. I might invite people, if they've got any observations or questions, you can type them in the box for us, and I'll just try and moderate those into the conversation as we go along. But if that's all right, I want to say thank you so much, Kasia, for the most amazing, insightful 20 minutes. Let's all step out of the room for 5, take a breath, and we'll see you back here at 8 for part 2. Thanks, everybody.
Thank you.
Hi, welcome back, everybody. And you're joining us for the second part of our evening webinar this afternoon. Terrible, thanks for asking, which we're joined by Dr. Kasia Maksym, who's talking to us about her work in maternal and fetal assessment, especially with some of the most high-risk pregnancies that people see. So just before, we were talking a lot about kind of the work itself and Kasia's journey into that, but she mentioned that she's currently engaged in a PhD study on top of all of this, right? And I thought it might be really interesting, you know, just spend a few minutes hearing about that. So, you know, where did that come from? And what are you studying, Kasia? And then we can perhaps understand a bit about where some of these issues are fitting in to the broader picture about how people are feeling and coping. Yeah, so why a PhD and how?
I guess I cannot live without the challenge. And when the things are getting more routine, then I'm starting to looking for something else. And to be honest, working with these high risk patients sort of lended an opportunity to do some research. Especially the data collection is easy because I'm actually seeing the patients and I'm actually doing the ultrasound. So this is how it started. Actually, again, it was just a natural extension of my work. What is this all about? This is all about developing treatment for the growth restriction. Okay. So this is first part, which is checking how these pregnancies behave and what is different about these patients and their babies, and getting an ideas how we can help. And actually, there is potential way we can help with the genetic treatment. And we hope to start a trial after another couple of research of the actual drug. And yeah, so this is very interesting. It's a little bit like a making history. But a part of the research, a part of the physical side and measuring the baby and measuring the blood flows in various vessels and measuring many different blood tests is also the communication with the patient and helping them along this journey. So yeah.
Okay, and so tell us a little bit about, we're particularly interested, you mentioned earlier, you know, the high levels of stress and anxiety. And I'm not sure the words you used, but something I thought of was that kind of sense of absence of control, actually, was something else I sensed. So tell us a little bit about kind of technically what you're measuring and what you're finding in that psychological sense.
So yes, I think it's coming very much from unanswered questions, with us unable to answer a question. So what we're doing the questionnaires at diagnosis at enrollment. And we measure the stress level, we measure the anxiety level. And then once the baby is delivered, after they coming for the postnatal appointment, the brief of the pregnancy and delivery, we repeating this questionnaire and depression scales and postnatal post-traumatic stress disorder. And then recently, one of my students and me, we got these numbers together, and what we found that it is interestingly lower level of stress if we decided that the pregnancy needs to be ended. So once somebody made decision, and in this case it's us, then suddenly the stress drops.
Okay.
So very interesting, but easy to explain, I guess.
Yeah, interesting, isn't it? So, and have you got a sense? Do you think this is about knowing?
It's about knowing, and it's very much about knowing. A part of these questionnaires, we also have parents' evenings. So we meeting our moms and dads, and sometimes extended families, and this is to update them on where we are with the research, and to chat with them what they would change and what they expect, and what advice they would give us about how to manage them. And this is common theme coming in back and back again. I wanted to know if there is any test you can do and tell me that my baby will survive or die. I'm happy to take the test. I'm happy to be told that my baby might die, but because that is helping me to prepare myself and my family. If you tell me that my baby will be born alive and will live, this is extra bonus. So it's not about actually they in so very difficult situation emotionally. They don't really mind being told that this baby is in grave danger. They just want to know.
Okay. So I'm sure there are lots of people listening along as I am and thinking, recognizing that uncertainty, is really hard to live with, and also the value of expertise here. So particularly in someone, if I might say so, as clearly empathetic and compassionate as you are, Kasia, but somebody who knows what they're talking about, but also understands, and clearly does understand. So it's kind of interesting. So people who are left in that space where there is no clarity one way or the other, does their stress tend to amplify over time, or do you have a sense yet of what that's doing? Continued uncertainty.
It's not an easy answer to your question, because in medicine, the things, and especially in pregnancy, the things are changing. If we see the patient 1 week and she's coming next week, and the baby is still alive and the baby is still growing a little bit, it's still very, very, very tiny, but it's growing a little bit, then we say, listen, this baby is actually doing well. So we're changing, by probing the system, we're changing the system itself. Okay. And after a couple of weeks or 3 weeks' time, suddenly we are at 25 or 6 weeks, and we say, listen, your baby, even if it's born now, might have a chance. And then we're seeing them again in a week time and a week time. And then suddenly we are at 30 weeks and the baby is nearly a kilo. And then we say, listen, this baby will be okay. But the problem is, at the beginning of this journey, we don't know. And if it's happening, the mom is coming next week, the baby doesn't grow at all. He's still alive, but it's no bigger. It's still 300 grams or 400 grams. And we come into these 26 weeks or 25 weeks when potentially from the time point of view, it would be possible to deliver, but we won't make this decision because baby is less, the size of the baby is not yielding a possibility of saving it. So this is not easy answer for this one because this is very, very, very dynamic situation.
Okay. Thank you. Yeah, thank you. I realised afterwards it wasn't a great question on my part, and I can see time passing itself can be a positive in many ways. So I've got a question come in, which I'm going to bring in if that's okay, and with a thanks to the person who submitted it. Just asking with so this is really bringing us to the COVID context. I mean, so I want to precursor this question really by saying, you know, how has the pandemic impacted your practice and the patients you're seeing?
The COVID it was very bad on me. First, we changed our pattern of work. So I went into emergency rota. Okay. So I was on call more time than ever. A lot of appointments which did not involve scanning or taking blood from the patient were done over the phone. So the interaction between the patients and doctors were completely changed, and they are completely changed because still quite a lot of appointments are done over the phone. So the practice changes. This is the one thing. The other thing is I'm working in high risk situation for a long time, but there was always a case. So this patient came with this one, this happened, we done this, we treat with this, the patient got better, and case closed. But with COVID, suddenly everything got blurred. Suddenly the full intensive care unit was filled with the same patient, like a clones. And that was like faceless in a way patients, and additionally lying flat on the front. So suddenly we got this sense of mass destruction of humanity.
Yeah. And you're working at this point outside the specialty into more other areas of the hospital as well, by the sound of it.
So I was mainly on labor ward. I was saved because of my ultrasound skills. But yeah, we had a pregnant woman on intensive care, not the one. We had quite a few, and we were going to visit them and scan them and assess them and check their pregnancy. And postnatal women, so women who just delivered and been separated from the baby because they had COVID and they had to be ventilated. And so want you or no, I was part of the intensive care wardens, and this is when I saw it myself, and that was terrifying. That was proper pandemic.
Yeah. I mean, most of us, some perhaps some people here, but most of us have had don't have that intimate sense of the criticality of the threat to life and the experience of the management of that. Within that, you mentioned there something about the separation that took place sometimes for mothers delivering a child during the pandemic. And actually the question we got, it was just perfectly in that space, is asking, you know, did you see the kind of an impact, a mental impact on people being separated as partners as well as from children around birth during the pandemic?
Yes, definitely yes. In my hospital, we developed very quickly an option for the partner to be during the labor, but that was very limited option. Okay. So basically, when the patient was assessed, if she's labor or not, or she needs delivery or not, she had to come on her own. But once she was admitted to the labor ward, we were allowing the partner to come, because we have single rooms, so we can basically isolate them in a single room. The problem is, once the mom delivered, that's it. Partner has to go. So there was a little bit better, probably, in our setting than in others, but I saw it. So first it was separation with the baby when the mom got COVID, and the second was separation of this unit, which just become family. They were a couple, and now they become family, and they are not allowed to be family. They're not allowed to share the responsibilities and joys and sleepless nights.
Yeah.
But yeah, I can tell that there was a lot of stress going on. So we, in a way, the midwives and doctors, we sort of step in a little bit.
Okay.
And we were cuddling the babies and helping with breastfeeding a little bit more than usual, probably, in all this gear.
Yeah. Goodness, what an experience. Have you seen some of those, some of the partners who maybe were kind of pushed out of that picture? Have you seen them since, when they've come back, or do they not tend to come back for follow-up appointments as a family?
So if everything went okay, they won't be coming back. But they do come for sort of the brief if something happens during the labor delivery. We have a special clinic for this one. It's a birth reflection clinic led by the fantastic consultant friend of mine, Miss Luck. And I'm sure if there is only a hint that the partner wants to be there, he or she will be there definitely, because we feel that this is this is family. So they have to share burden of everything. And sometimes we had this conversation with my friends and earlier today. The thing is, partner, if he or she is during the delivery, is a little bit different angle of observation, what's going on, what we're doing, what's happening to the laboring women, what's happening, what the midwives say. So this is very important to include the partner in this reflection on the complications of labor or pregnancy or even a normal labor.
Okay, thank you. I think it's been kind of what's the word, implicit, and I should draw it out at this point. I think is to ask a little bit about, you talk with ease, if I might say so. I don't mean that it's easy, but with ease about the stress and the difficulty and the anxieties that people experience. So the mental health problems, but that's not the case for a lot of people. Perhaps for some of your patients too. And I just wonder, as I move us towards thinking about what we might collectively learn from some of the wonderful experiences and thoughts you've shared with us, do you sense that there are still some blocks for people around being able to talk about their feelings?
There is a lot of block. There's a lot of stigma on mental health, basically, and we as professionals, we cannot impose the mental health help on you. We can only offer you this help, and we can refer you if you are happy for us to do so. And I probably will be repeating myself, but what I'm always saying, and what I said already to you yesterday, adulthood is not doing everything yourself. The adulthood is to learn how to open to other people and how to get help from others and how to manage the others to be your troops. And this is very important to remember. Being an adult is not, you don't need to take the burden on yourself. Being an adult means learning that you can be low, you're allowed to be stressed. And if you start talking about this, you will get help.
Okay, that's a very nice take. Thank you. Yeah, so I think the idea of that actually there's a kind of maturity in, that it's a reflection of a kind of maturity to be able to recognise those things is a really interesting kind of way of considering one's approach to it. We've got another comment really, and a part of a question coming here, which I mean, it's a slight side, but I do want to include it because it's a great one. Somebody's asking, how do you fit all this together, right? The intensity of the work, the PhD. How do you do it?
I don't know. I don't know. The work-life balance is non-existent.
Okay.
It's very, especially now when you're working from home, and especially now when the research is still done from home, it's very, very, very difficult. So what I'm trying to do, I'm trying to sort of compartmentalize my day. I'm pushing myself to the limit, writing up my upgrade stuff, and then I'm taking 2 hours and I'm going gardening or cooking something. I made the jam today, and then I'm making slides for presentation, or
Yeah.
I'm going, cycling like a crazy around London, and then I'm sitting back and doing something. This is the only way.
Okay. Yeah. So, yeah, kind of extraordinary self-management that's taking place by trying to fill it with different things. I mean, I want to connect that back to really to the issues that might begin to close the loop for this evening with you, which is to ask that you found some ways there to think about self-care. Uh, I'm not sure whether they're all healthy or whether they're ways of just coping at the moment, but sometimes that's okay. And we've talked about the fact it can be difficult because of stigma for people to reach out. What do you think are the things that make it easier for people to find space to open up about when it's tough?
Um, Now it's especially tough because in a couple of years ago, when we would organize something like that, I would come to Durham. We would have a dinner on Thursday,
Yeah.
and then we'll sit in a nice place, and then we'll have a chat in a forum or things like that. And then after that, people will come and sort of we'll have a chit chat and little conversation, or even end up in some nice place up the castle. Uh, but now the separation of between us, the physical distance, despite having chats like that, is especially difficult. But keep these chats. Even 5 minutes on a Zoom or Teams with your friends or family is helping. If you can see them, like we see each other now, is extra benefit, because you see the expression, you see the hand movements and things like that. But even if you can only speak on the phone, or even if only you can drop a line, email or text, is very important. The human species, we are a family. And you want it or not, the contact in between us has a healing properties. So first and foremost, keep in touch. And the second thing, when the things are getting really bad, and I'm using it, when I'm very tired, or I'm very tight on my dates, or I had a very bad set of nights, I'm taking a little break. I'm taking break from myself.
Okay.
I'm allowing myself to have a day off. Sometimes this is not a day off. Sometimes this is a couple of hours off, but I'm clearing my mind. I'm stepping back
Okay.
and doing this very interesting exercise I stepped a couple of years ago. When the things are not going well in your life, and generally we judge ourselves very harshly for anything we're doing. So when I have a day like I can't write anymore, I'm stupid, then I'm asking myself, hey, why you are where you are? Did you pay somebody? Did you pull a favor? Did you, I don't know, done something so you paid for the favor? No, you are here where you are because you are clever. Because you worked hard for this using your cleverness, and this is why you're sitting in front of this screen and writing these stupid theses. Not because you're stupid, because you are clever.
Yeah.
And that helps.
That's very beautiful. Thank you, Kasia. I'm just going to pause then and see if anybody's got anything else they wanted to bring to the table. Otherwise, I'll begin to draw us to a close, I think, this evening. And while I'm just waiting to see if anybody's going to pop anything in there, just a couple of reflections from me. I think it's extraordinarily privileged. It's extraordinary privilege, Kasia, to hear from somebody whose days, whose mind and whose heart is so full by the work that you do, the service that you offer to people, who are in crisis of one form or another. Their lives are in crisis, right? And as you were saying, not so many get that happy ending that they might be looking for. But I've heard some really important things here about uncertainty, people's experience of that, and why it can be so important, what it kind of trumps sometimes, which is even more important than the outcome itself. Sometimes can be feeling that one knows what it's likely to be, that sense of being able to be prepared for something. And I think the other thing I've really heard from you this evening is something very insightful about the lack of distinction that you make, actually, I would say, between care as expressed to others and care as expressed to the self. So where you've put yourself on the line, over and over again, you've talked in exactly the same way, actually, about the things that you would offer and kind of ask a bit other people to think about doing to look after themselves as the way that you do it for yourself. Something very humanizing about that, incredibly powerful. So I think I want to say a personal thank you for your time, and you can see that you've inspired Dan. And I think, Dan, just go for it, right? There's my personal advice on a PhD front. You never know until you've gone for it. So do get in touch, Dan, if you want to talk a bit more about that as well. But a thank you, Kasia, for giving us your time in such a busy life to share these extraordinary experiences and the generosity of your soul. Thanks to Steph for making touch with you and organising this opportunity. And on behalf of everybody here tonight and college, we say a huge thank you, and thank you for the work that you do for all those people, all those mums, dads to be, and the children out there. It's just extraordinary. It's been a pleasure and a privilege to have you with us this evening. Thank you, Kasia.
Thank you very, very much. It's real pleasure to share this, and I guess it's beneficial to me as well in a way. And I just got a beautiful comment from one of you, and I'm telling you, if you even start thinking, should I do PhD or not, just stop thinking and do it.
Excellent advice. Okay, so the Saturday night message from here at Terrible Thanks for Asking is, don't think about it, do it. If you're in doubt. Lovely. Can I say thanks once again to everybody for joining us this evening for what's been a remarkable, really remarkable, touching and impressive experience. Kasia will be dropping a line to say thanks, but thanks again from us here now. And we say to everybody, the best of the evening that remains, and take care, enjoy the weekend, and thanks very much. Good night, everybody.